Bismillah ar-Rahman Rahim. Assalamu alaikum. Dear colleagues and PGs, today we shall discuss portal hypertension and the role of beta blockers in it. This discussion has got two parts. In the first part, we shall discuss the underlying pathophysiology of portal hypertension. And in the second part of this discussion, we shall explore the role of beta blockers in portal hypertension and see what is the current consensus on the use of beta blockers in such cases. So as I said, the title for today's discussion is portal hypertension and beta blockers, current consensus in 2022. And this is the first part of this discussion. When we say a patient has got chronic liver disease, we can divide the chronic liver disease into two stages or two phases. The first is the early chronic liver disease, and the second is the advanced chronic liver disease. By early chronic liver disease, we mean no cirrhosis, while by the term advanced chronic liver disease, we mean cirrhosis. It means if we say a patient has got early chronic liver disease, it means patient has got no features of cirrhosis or patient is not cirrhotic. When we say advanced chronic liver disease, it means the patient has become cirrhotic. The cirrhosis is again can be divided into two stages. The first stage, that is the compensated cirrhosis, and the second stage is that of the decompensated cirrhosis. So cirrhosis, the first stage is compensated cirrhosis and then the decompensated cirrhosis. The compensated cirrhosis can further be divided into two stages. The first stage of the compensated cirrhosis and the second stage of the compensated cirrhosis, and then the decompensated cirrhosis. The compensated cirrhosis first stage is the one when the patient has got no varices and patient has not developed any ascites. In the second stage of the compensated cirrhosis, patient has developed varices but no ascites. While in the decompensated cirrhosis, either the varices which the patient had developed in stage 2 of the compensated cirrhosis, they bleed, or the patients developed ascites, or both of these. So if we rethink the patients in first stage of compensated cirrhosis, where there are no varices and no ascites, if these patients develops varices, the patient will enter into stage 2 of the compensated cirrhosis, and when these varices bleed, the patient will become decompensated. Or if the patients develop ascites, then again it will be a decompensated cirrhosis. But it's just possible that the patient is in the stage 1 of the compensated cirrhosis and the patient developed ascites, so that patient will directly jump into the decompensated cirrhosis. So the patient can progress from stage 1 of the compensated cirrhosis to stage 2 of the compensated cirrhosis, and then the decompensated cirrhotic stage are the patients from the stage 1 of the compensated cirrhosis may directly jump into the decompensated cirrhosis. So the story will be no cirrhosis, then stage 1 compensated cirrhosis, then stage 2 compensated cirrhosis, and then the decompensated cirrhosis. Or patients in no cirrhosis, then stage 1 compensated cirrhosis, and then directly jumping into the decompensated cirrhosis. What does it mean by this? By saying no cirrhosis means that the portal pressure is normal. When the patient has got normal portal pressure, the patient is non-cirrhotic, or the patient has got early chronic liver disease. But once the patient develops portal hypertension, we say the patient has become cirrhotic now. And this portal hypertension can be of two stages. The first stage is that of clinically insignificant portal hypertension, and the second is that of clinically significant portal hypertension. The clinically insignificant portal hypertension is when the patient is in stage 1 of the compensated cirrhosis. When the portal pressure was less normal, it was no cirrhosis. When the portal pressure increased, it was the clinically insignificant portal hypertension when the patient has got no varices and no ascites. When there is further increase in the portal hypertension, then this is called clinically significant portal hypertension, and now the patient is in the stage 2 and stage 3. To further explain this matter, let's go to the underlying numbers of the portal pressure. Then when we say this is the normal portal pressure or insignificant portal hypertension or clinically significant portal hypertension. So the natural course is when the hepatic venous pressure gradient is less than 5, this means normal portal pressure, it means no cirrhosis. Once this hepatic venous pressure gradients increases, then 5, 6, 7, 9, 8, 10, till 10, from 6 to 10, when it increases from 5, it means portal has developed portal hypertension and now the patient has become cirrhotic. When it is from 6 to 10, this is clinically insignificant portal hypertension, and this is a stage which we call the stage 1 of the compensated cirrhosis, when there are no varices and no ascites. But once this 10 figure is crossed and no the portal, the hepatic venous pressure gradient is more than 10, then from 11 and 12, these two, this is the stage 2 of the compensated cirrhosis. Now these patients will develop varices. Now this patient will develop varices, and this is the first phase of the clinically significant portal hypertension. And when the portal hypertension value is more than 12, then this is the stage characterized by the decompensated cirrhosis. When these varices which were developed in this here, they will bleed, other patients will develop ascites. So depending upon the hepatic venous pressure gradient, when it is less than 5, this is normal portal pressure, and this is the feature of the non-cirrhotic stage of the chronic liver disease, which we call early chronic liver disease. When it is from 6 to 10, this is clinically insignificant portal hypertension, and this is present in the stage 1 of the compensated cirrhosis. From 11 to 12, this is clinically significant portal hypertension, and this is present in the stage 2 of the compensated cirrhosis when the varices develop. And more than 12, this is the clinically significant portal hypertension when the patient's varices they bleed or the patient developed ascites. So this is very, very important that we should, if a patient has presented to us with the variceal bleed or ascites, we must think that the portal hypertension in this patient is more than 12. When you do the endoscopy, there are varices, but there is no ascites. You say that this patient has got portal pressure of the 11 to 12. It is clinically significant portal hypertension, but it is 11 to 12. When the patient comes to you with cirrhosis and you do the endoscopy, there are no varices and there is no history of ascites, ultrasound is not showing any ascites, it means this is the stage 1 of the compensated cirrhosis, and by and large the portal hypertension value is somewhere between 6 and 10. We can further confirm, or we can further take the help of the EPRI, that if depending upon the EPRI value, you can presume that what will be the underlying portal hypertension or hepatic venous pressure gradient, as we are not checking in clinical practice this hepatic venous pressure gradient. Still, this is the research protocols. So by the help of the simple parameters, you can think, or you can make a mind that what will be the hepatic venous pressure gradient in that very patient. If the EPRI is in the non-cirrhotic stage, the EPRI value may be less than 0.5 or 0.6 to 1.5. So remember, if the EPRI value is less than 1.5, it means there is no cirrhosis and the hepatic venous pressure gradient is less than 5. But once if it is from 1.6 to 3.5, it means that there is portal hypertension, but it is from 6 to 10, and now this patient will be not having varices and no ascites. But when it is more than 3.5, it means the clinically significant portal hypertension has developed. And when you see these patients, there will be varices, there will be history of ascites, there will be history of treatment for esophageal variceal bleeding or gastric variceal bleeding. The second parameter or score is the FIP4. When its value is less than 3.5, this is the normal portal pressure. But when it is more than 3.5 or 3.6 to 5.5, this in most of the cases, this correlates with the clinically insignificant portal hypertension, and more than 5.5, the clinically significant portal hypertension. Coming to the fibroscanning values, when these are less than 15, it means there is no cirrhosis. There may be advanced fibrosis, but no cirrhosis. But when it is more than 16, so 16 to 25, it's in most of the cases correlated with clinically insignificant portal hypertension, but more than 25, it correlates with the clinically significant portal hypertension. So this is the further division of that. The transient elastography value more than 15, 16 to 25 or more, this is the stage 4, and now there is portal hypertension, and depending upon the APRI and the FIP4 values and the elastography values, if this is in this range, then this is the clinically insignificant portal hypertension, but more than this, it will be in the clinically significant portal hypertension. And now this will be the patients when you examine the patient, if the patient presents to you with venous bleed or ascites, and when you check these APRI, FIP4 or transient elastography, these will be the values. And when you check the hepatic venous pressure gradient in this patient, which we are not checking in the clinical practice, this will be more than 12. So these are the non-invasive parameters which can tell you, it can give you a good idea that what may be the underlying hepatic venous pressure gradient in my patient. Another, the correlation of this hepatic venous pressure gradient is when it's a non-cirrhotic or normal portal pressure, these patients may or may not develop hepatocellular carcinoma. The risk is minimal in this group. While in case of the compensated cirrhosis, there is risk of hepatocellular carcinoma, but it is less than when the patient has got decompensated cirrhosis. So this is the correlation of the occurrence of the HCC in these patients. Minimal in the non-cirrhotic stage, then it is there, but less than what it is with the decompensated cirrhosis. And coming to the hepatic encephalopathy, in non-cirrhotic stage and in the compensated cirrhosis, when the hepatic encephalopathy develops, this develops as a result of acute and chronic liver failure. While in the decompensated cirrhosis, it develops as a consequences of liver cirrhosis. You don't need then the ACLF scenario for these patients, and these patients can develop HE as a complication, as a consequence of their decompensated cirrhosis. Another good parameter is that of the platelet counts. When the platelet count is more than 150,000, probably your patient lies in this group. When it is less than 150,000, then the patient has got the cirrhosis liver. So, dear colleagues, this is important that when a patient comes to you, you must think to which category my patient belongs, and we don't check the hepatic venous pressure gradient as routine, but with the help of these parameters, we can reasonably say whether my patient has got the normal portal pressure or the portal hypertension, and whether this is the clinically insignificant or clinically significant. This is very important, and we can presume. So with this background, that when we make our mind, when we think that what is the probable portal pressure in this very patient, we can think about using the beta blockers in these patients. This is the we presented our data, our center data in 2016 Tokyo Basel, and this was the 2,780 patients data. And this is the what are the complications when they present for the first time. And when what we see, the ascites is the most common complications when in our patients when they present to us, followed by the overt hepatic encephalopathy, then the presence of the varices, then the variceal bleeding. Coagulopathy is the another one, and then the HCC and the HRS. So the most of our patients, they do present with the ascites, and this is what I'm telling you, that when we will be in the second part of the discussion, this is important that the beta blockers can prevent the occurrence of the ascites in cirrhotic patients. Though the data has shown, the study has shown that even the beta blockers role is not only to prevent the development of the varices or but to prevent the bleeding esophageal varices or to prevent the varices from bleed. They are important in prevention of the appearance of the ascites. This we will discuss in the second part of this discussion. So, coming to the pathophysiology, this is the normal vascular anatomy of the liver. We all know the superior, the splenic vein and the inferior mesenteric vein, then the splenic vein, and the superior mesenteric vein. They make the portal vein, and the portal vein, it supplies the blood to the liver. It takes the all absorbed nutrients to the liver, where the those nutrients, they undergo different metabolic processes in the metabolic factory, in the metabolic industrial area, and also the blood, the oxygenated blood is supplied to the liver by the hepatic artery, and then these the portal veins, they divide to the sinusoidal level, and then from there the blood is drained in the hepatic vein. So the blood supply to the liver is the hepatic artery, which supplies it the oxygenated blood from the liver, and the portal vein, which supplies or which brings all the absorbed nutrients from the intestine to the liver, and these nutrients, they undergo metabolic processes, and then the blood is drained back to the heart from the hepatic vein. This is we all know, and this is we all know that the again the this is the hepatic artery, the portal vein, and then this is the inferior vena cava, superior vena cava, and these are the different lobules of the liver, and these are the different hepatic veins: right hepatic vein, left hepatic vein, middle hepatic vein, inferior vena cava. And when we see it at the lobular level, then this is the anatomy, that this is the branch of the hepatic vein, this is the bile duct, this is the branch of the hepatic artery, and then these are the sinusoids, the cords of the sinusoids, the hepatocytes, then this is the hepatic venule, and then the drainage bag. So we all know this, and this is important when we think about the pathophysiology of the portal hypertension. Another basics physics rule which we should not forget, one is the Ohm's law. Ohm's law means that the voltage is directly proportional to the current and resistance to the current of the current flow. This is the current flow, and this is the Ohm's law, that V is equal to the current multiplied by the resistance. This Ohm's law can be replaced to the blood flow as well, like P is equal to F into R, where P is the resistance gradient through the portal venous system. So this is the portal venous system. F is the flow of the blood, that what amount of the blood is flowing through the portal vein, and R is the resistance to flow of the blood. So the Ohm's law can be applied to the blood flow in the portal vein, that the P or the pressure gradient through the portal vein is directly proportional to the multiplied product of the flow as well as the resistance. Then there's another law, that is the Poiseuille law, and it says that the radius R is equal to 8HL divided by the PR4, where H is the viscosity of the blood, that what amount of blood is being flown, what is the viscosity of it. L is the length of the blood vessel, the portal vein, and then the R is the radius of the blood vessel. What is the diameter of that? So the diameter of that, the resistance, this resistance, which is the resistance to blood flow, this is directly proportional to the 8 h, the viscosity, and the length of the blood vessel divided by the PR and 4. The P is here the pressure gradient. And when we replace the R by these laws, but we get that the pressure gradient is directly related to the flow of the blood multiplied by the A divided by the pressure gradient into the radius into 4. So it means small decrease in vessel radius results in large increase in portal pressure. So when there's slight increase, the decrease in the vessel radius, small sorts of constriction will lead to huge increase in the portal pressure. And this is important when we will be discussing the role of the beta blockers, that how much small change in the diameter results to the decrease or increase in the portal pressure. This will be important. So now to sum up that the portal venous pressure is equal to the blood flow multiplied by the resistance. So the portal hypertension can be because of the increased blood flow. When the blood flow increased, it will lead to the portal venous pressure, or increased resistance to the blood flow. If the resistance is increased, again the portal venous pressure will increase. So the portal venous pressure is directly proportional to the blood flow and the resistance. Coming to the resistance component, an increase in the portal venous inflow sustains portal hypertension. So now let's see how this resistance can be increased to the blood flow. So the increased resistance to blood flow, it may be pre-hepatic, it may be hepatic, and it may be post-hepatic. The pre-hepatic, when there is portal and splenic vein thrombosis, when there is AV fistula, when there is splenomegaly, these are the conditions where the pre-hepatic resistance is increased to the blood flow, and because of this there is portal hypertension. So portal hypertension, either it may be because of the increased portal blood flow in the system, or because of the increased resistance. And increased resistance may be pre-hepatic or before the liver, and this will be either because of the portal and splenic vein thrombosis, or AV fistula, or splenomegaly. So this is the portal vein, there is the thrombus is formed. So because of this, there may be portal pressure. Coming to the hepatic component, what the hepatic causes in the liver, these can be pre-sinusoidal, sinusoidal, and post-sinusoidal. The pre-sinusoidal, this is a sinus. So the pre-sinusoidal causes, these are the schistosomiasis, primary biliary cirrhosis, sarcoidosis, congenital hepatic fibrosis, and idiopathic portal hypertension. All these are the causes for pre-sinusoidal increase in the resistance to the portal blood flow. Coming to the sinusoidal, cirrhosis is the good example of the increase to the resistance of the portal flow. So this is the sinusoidal site, or the sinus is the site for that. Post-sinusoidal, these are the veno-occlusive disease, which can lead to the increase to the resistance of the blood flow in the portal system. And the post-hepatic resistance, these are the Budd-Chiari syndrome, the membranous obstruction of the inferior vena cava, or constrictive pericarditis. So, as just to sum up again what I discussed with you, that the portal hypertension may be either because of the increased blood flow or because of the increased resistance to the blood flow. The increased resistance to blood flow, it may be pre-hepatic, hepatic, or post-hepatic. In cirrhosis, we will see later on that there is increased in blood flow as well as there increase in the resistance at the hepatic level. So this is the main pathophysiology of the portal hypertension in cirrhotic patient. And we discussed all these causes, that what are the causes of pre-hepatic increased resistance to the blood flow, then hepatic causes, and the post-hepatic causes. Hepatic causes can be divided into pre-sinusoidal, sinusoidal, and post-sinusoidal. There is another chemical role of nitric oxide in the portal hypertension, and we know that the nitric oxide is the most potent vasodilator. When there is high nitric oxide, it means there will be vasodilatation, and when the concentration is less than normal, there will be increased sensitivity to vasoconstriction, and there will be decreased endothelial response to vasodilators. So I repeat again, when the nitric oxide concentration is higher than normal, there will be vasodilatation, and when it is low, there will be increased sensitivity to vasoconstrictors and decreased endothelial response to vasodilators. What's its role? I told you that there is in the cirrhosis, there is increased in blood flow and there is increased in resistance, and the increased resistance is at the sinusoidal level. So why the blood flow is increased? There is paradox. There is paradox of the nitric oxide concentration in cirrhotic patients. In this splanchnic circulation, there is increased in nitric oxide concentration. It's more than normal, while in intrahepatic circulation, it is less than what we see. So, as I told you before, that when the concentration is high, there will be severe vasodilatation. And so it means there will be a lot of blood pushing into or coming into the being in the circulation, and where there is less decrease in nitric oxide's concentration, there will be vasoconstriction. So according to this, because of the increased in nitric oxide concentration in the splanchnic circulation, what we see severe vasodilatation and increased blood flow into the portal vein. So the blood flow is increased in the portal vein, while on the intrahepatic circulation there is this normally nitric oxide plays a major role, while in the cirrhotic patients the nitric oxide activity is reduced and vasoconstrictions is increased. So this is the normal histological picture, and this is the cirrhotics when the nitric oxide concentration is low and there is increased resistance. So one point is that this increased resistance point is that it is of two types. One is fixed resistance, that is because of the collagen deposition of the fibrous tissue at the sinusoidal level in the hepatocytes, the liver, while the second is the reversible vasoconstriction, that is because of the vasospasm. I told you that when there is decreased concentration of the nitric oxide, then it results in the vasoconstriction. So this is important when we will use the beta blockers. We will hit either also the vasodilatation part, as well as we will hit the reversible resistance, that is the sinusoidal vasoconstriction. So to summarize, intrahepatic resistance, there is two components. One is irreversible or mechanical component, which is related to distortion of the liver microvascular architecture, and second is the reversible dynamic component, which is related to the endothelial dysfunction leading to an increased in hepatic vascular tone, and this results in the decreased availability of endogenous vasodilators, mainly nitric oxide, and increased release of vasoconstriction, that is the prostanoids, endothelins, and angiotensin. So, dear colleagues, in this part, we learned that the portal hypertension, it is either because of the increased blood flow into the hepatic vein, or it is because of the increased resistance to the blood flow in the hepatic vein, the portal vein. So when there is increased blood flow in the portal vein, it will lead to portal hypertension. And if the resistance to this portal blood flow is increased, again there will be portal hypertension. This resistance to the portal flow is of two types. One is irreversible, which is because of the deposition of the fibrous tissue in the hepatic parenchyma, and that is irreversible. And second is the vessels within the intrahepatic vasculature, which has gone into constriction phase because of the decrease in the nitric oxide. This is the almost 30-40% of the resistance is the reversible one, and this is the component which, if we hit with the beta blockers or with the drugs, we can decrease the resistance a lot, and we can relieve the portal hypertension in these very patients. So what's the role of beta blockers in this portal hypertension? We shall discuss is in the second part. Till then, goodbye, Khuda Hafiz.